Hello to everybody. I was delighted to be speaking on an area of my practice which I find quite interesting, and that's the conundrum of how to manage tailgut cysts. And we were able to discuss the breadth of abnormalities in the presacral space, or as some others call it, the retrorectal space, and give some clarity as to where we think we're going in terms of how we best manage these. Introduce the fact that there is an international consensus evolving in this area, and hopefully address some of the quandaries that the audience may have had as to how to best manage this group of patients. The direction of travel, more and more we see the importance of imaging, particularly MRI-based imaging in the assessment and actually the diagnosis. More and more of these lesions are falling out of MRI scanners than we've ever seen before, and because of the liberal availability and application of scanning to patients nowadays, we're seeing more and more appear. So the denominator is enlarging, but with that, the quandary as to what we should do. In terms of where the direction of travel for the future is, I think these lesions should be managed within a specialist centre, discussed within a specialist multidisciplinary team, and I think we will see more patients being surveyed and avoiding surgery, and those that do require surgery being very aggressively managed, particularly if there's a concern about malignancy. In terms of what the future technology will hold, I think AI will have some role. We're building a repository of imaging in the UK to try and better understand the volume of this disease, and also understand whether we can simplify the understanding of the radiology by not only protocolizing the reports, but also bringing in artificial intelligence to see if it can pick up features with imaging which may suggest that there is a likely malignancy. The current generation of trainees in surgery have been given a fairly bad deal, and I'm very worried about how the future is going to be for that set of surgeons. It is a group of surgeons that have come through COVID with a restriction on their activity in theatre, a restriction on the educational aspects of their progress, and the evolution of new technologies such as robotics. Although it seems to enhance certain things for some patients, it does appear to be restricting opportunities for trainees to be trained in certain cases that in eras gone by would have been regarded as the cases that they should have. Open surgery, laparoscopic surgery, so on and so forth. So I think that is something we will need to seriously think about and address. And I still think there's a significant role for open surgery, a significant role for laparoscopy. And although this current generation will move towards more robotics, I think we will need to be more thoughtful about how we deliver this so that we don't disenfranchise a generation of trainees and also disadvantage them in terms of the training that they get. My concern being that we'll push training further into the years where they become consultants and actually set up problems that never really get resolved. So I think rationalising who does robotics, for example, and which cases should be done will mean that we preserve training while still delivering optimal care for patients.